All right, guys, welcome to the 10th episode of Just a Little Salt. First and foremost, I want to apologize. I have a man cold. Luckily, I'm not acting like most men, and I'm not laid up in bed right now with tissues and acting like I'm dying. I'm going to record this podcast. I'm going to power through it because I've got a real exciting guest today. I'll let her introduce herself to you guys. Just tell them a little bit about yourself, and then we'll dive right into the questions.
All right. Well, thanks for having me. I appreciate the invite to be on your podcast. My name is Alex Jabr. I am the founder and creator of Emergency Resilience, which is kind of a small platform for continuing education on specialty topics. The way I kind of describe it is these are the kind of marginal topics that kind of get pushed aside that people don't really want to focus on head on. I kind of find the weird things and focus on that. I'm an accredited CE provider, so I get to create my own courses. I have my own committee, full deal. And so I get to put together some trauma-informed CE courses for providers, and they get education that counts towards CAPCE credit. Yeah, that's the biggest thing. I'm a licensed paramedic. Haven't been on the ambulance in a while, but unfortunately due to a pretty severe back injury. But I've been grateful that I was able to pivot into education, then continue my own education. I have a master's in mental health, which was the degree that I pursued in death, grief, and bereavement. That's where I wrote my curriculum, death communication. And then I got my PhD in psychology. So I'm just really grateful to be able to have these two worlds intersect and have a community that I get to learn from every day in, the same opportunities that I get to teach them.
Yeah, all your stuff is really, really fascinating. Coming from a firefighter paramedic, I know my department and many other departments I've been a part of, death notifications is something that we don't really get taught and are just very, very inexperienced in. So if you can, for the people that don't know, can you talk about what exactly is death notification and why it's so important to do it right?
So the curriculum I created is death communication, which includes the notification part. But really, when it comes to notifications, it's a little different for EMS providers and firefighters that are offering, ALS support. Because when you've got a workable cardiac arrest and you're on scene for 20 to 30 minutes with these families, which is a lot longer than historically we were. When I was EMT and into my first couple of years as a medic, it was load and go. It's like you got maybe your first round on board and you were going. If they weren't dead right there, you were leaving very quickly. And then it shifted to, don't want to transport. If there's active CPR, you have a higher survival rate. If you stay at play, kind of thing. So then everything changed, and there's a lot of agencies out there that still haven't adapted that high performance CPR of staying on scene and not transporting until you get ROSC. But for those who are, all of a sudden you couldn't just ignore the family. You had to learn to, have this continuum and this continuous conversation with them. But ultimately, it does fall on the crew, usually one primary person, at least a secondary person, but ultimately everybody's impacted, to tell the family that their loved one is dead and having to, use those words. On occasion, let's say you're there for a welfare check. And we've had those where, you get called for a welfare check and whoever it is that's calling for it lives out of town and you beat them to it and you determine that the person's, RDBOA, then you have to kind of give the formal notification of, hey, I have bad news that is about your, father who we saw, who you were calling about. We found him here. Unfortunately, it appears that he died a while ago and you kind of getting that information at that point.
Yeah, me personally, I got my paramedic when I was 24 years old. I found out real quick, just being a young kid and you're put in this position to relay that information to a family that's experiencing one of the worst days of their lives. And like I mentioned earlier, we don't really get taught how to do that. So you kind of find yourself along the way. Mm-hmm. And luckily, I feel like I realized really quickly through good preceptors and just things I noticed how to do it effectively. Of course, there's always different things you can learn. But on that same aspect, when I'm not the lead paramedic and I've been on scenes, I've noticed other paramedics, how they do it. And it's just, it's not good. And that's why I believe so strongly in this type of education, because not everybody are given the right tools to communicate this efficiently. So what would you say would be the biggest mistake first responders make when delivering a death notification?
Well, this might be a biased take on it because this was my mistake in the first couple of years that I was, responsible for being kind of taking the lead on it. Is avoidance. Is I think the biggest mistake we made is avoiding the family and not wanting to talk to them. When we were transporting after cardiac arrest, as soon as I heard them bringing the family back, it was like, get my signatures and I'm out. I did not want to see them. I wanted nothing to do with it. So I haven't always been this way and this much of an advocate for it. I've been on the other side of it as well. But I'd say it's probably that. And then trying to soften the delivery with the terms that we use. We have a lot of different euphemisms for the word death and dead and died. And when we use things like passed away, we lost them, no longer with us, that kind of stuff, that kind of ambiguous messaging can get really confusing for someone that is in a heightened state of acute stress. And so we have to be as clear as possible, not to mention any type of cultural differences. So when you have people that, don't necessarily come from the same background as you, these euphemisms aren't going to make sense. So you have to be as clear as possible. And you can soften your tone soften your message with like tone and body language and cadence, but you really have to use the word dead and died.
Oh, that makes perfect sense. Luckily, that's something that was taught in my class, not using those euphemisms and everything.
That's good.
Yeah. Is there a moment that you can remember early on in your career that really changed how you approach those death notifications, like now?
Yeah, I can think of a couple. And all three of them were kind of centered around avoidance. The first one was actually just like 2 weeks before I started EMT school. So technically wasn't when I was in the field. I went through EMT school right out of high school. I was 18 and my mom had died suddenly. And my sister tasked me with delivering the news to her best friend, who I knew as well. Her son and I were the same age. We grew up together. And at the time, I didn't think much of it. I mean, my sister is 10 years older than me, and she took the lead on everything. And when I got home that day, she's like, I just can't tell one more person. I can't break one more person's heart today. And she died very suddenly, unexpectedly. And so I was like, yeah, no problem. I'll call Debbie, no big. And I totally screwed the pooch on it. It did not come out at all like I had intended. I did use the word dead. Okay, I got that part right. But my delivery was poor. And, I ended up getting yelled at by her husband, who then made me cry, which was its own thing. And like a lot of people, I recently shared that experience on social media. I hadn't. I normally share it in this workshop that I do for death notifications. I'll open up a little bit more in person. But some people have a lot of opinions about that. And like, oh, you were 18, you shouldn't have been doing that. But 18 at my age, 18 for me was a lot older. I had to grow up very young. Yes. I was working at 12, taking care of my mom at 15. I dropped out of high school to be her primary caregiver. So 18 wasn't exactly, what my niece and nephew will be at,
yes.
in 3 years. I would never trust them with that. So it really wasn't the most, ridiculous thing to ask me to handle this. And I really thought it would be easy, all things considered. And it wasn't. And that really was a moment where I knew I messed up, and I thought, oh, well, they're going to teach me everything I need to know in EMT school how to do this right next time. That didn't happen.
Yes.
And, and what you described is experiential training. We watch and learn. We learn from the people around us. And sometimes we have some really good mentors. There's some people that are just naturally really good at it. But sometimes these bad habits get passed on as well. And that's the unfortunate part about it. And without some sort of structure, some sort of guidance, we're just freely going out there, doing it any way we want. And what ends up happening is everybody thinks it's someone else's job, and then nobody ends up doing it and doing it correctly. So.
Exactly. And it's, in emergency medicine, it's so hard because you can experience so many different deaths, like different type of deaths, and your patient can be different ages, and the family members on scene can be different ages. And, there's so many different factors, and each time is different, and they might react differently. But as long as you have that solid base, I believe that that's really, really helpful. Because like I talked about, some of the ways I've seen people deliver death notifications, it just makes me cringe. And I'm like, we need better education out there, because we're taught everything else about our job except that, it seems like. So, hopefully in the future, things like this can continue to be implemented, and it will help in the long run. When you deliver these death notifications, how do you prepare yourself mentally?
I think it starts way before you're even called on scene to these kinds of calls. I think that's where training comes in. That's where you have to integrate this type of training, or this type of, these types of topics into routine training. So my belief is that anytime you are practicing CPR, so CPR class, ACLS, PALS, hand pivot, whatever it is, maybe you're in school, medic school, mega code, EMT school, CPR, rescue, kind of station. Anytime CPR is being practiced, you need to at least give mention to when it doesn't work. We need to at least regard it. Like, I don't expect it to take up 90% of the class, to this, reflect 90% of the patients that are going to die in the hospital setting that go into cardiac arrest, but at least 10% of it should be. And these conversations, especially with with your crew, how do they feel about working up pediatric cardiac arrest on scene? What's everybody's take on that? That is not a conversation that needs to be had after the dead baby's in your arms.
Oh yeah, 100%. I mean, not just fire and EMS experience it, police officers do as well. If you had to give one piece of advice to fire, EMS, law enforcement professionals, what's something you wish all of them were trained on regarding these death notifications?
I don't know which one thing, but if I had the law enforcement's attention, I would certainly tell them, because at least where I worked Southern California was the majority of my time in the field. And law enforcement was so good about being on scene first with pediatric cardiac arrest, but because they're portable, they would run outside with them. And then we'd hot potato the kid in the ambulance, and we'd take off, and good got done. It's delivered to soup sandwich to the ER. If they could just stay inside, because a couple times those babies were not workable. And then now you really compromised the crime scene. I would say if I had their attention at all, it would be to just stay there. You hear sirens. I know it's tempting to want to run with them. But for everybody else, I think I would want them to understand that the response from the family is not their fault. Generally speaking, there are things we can do to make it worse. I'm not saying that there isn't room for human error. But I think the thing that we avoid the most is being the messenger. And when someone is, crying and breaking down emotionally in front of you, you have this, need and desire to help them and to fix it. But the best thing you can do for them is technically nothing. But, some people hate this word, hold space. Let them just unravel and don't absorb that. We have to have boundaries as well. And we have to go discharge that, go for a run afterwards, get that out of your system. But their grief is not your responsibility to fix. That is probably one of the most important things I hope people take away from this.
Yeah, it's like you read my mind. My next question was, what's the difference between being professional and being human in those sort of situations? I mean, I've been there. Family members are breaking down, and you want to be that arm to lean on or shoulder to lean on.
And it's just, you have to excuse yourself. And we're conditioned to do this, right? You hear the tones drop, you respond, you fix, you go back, right? And if you can't fix, you take them to the hospital where someone will magically fix them there. You create solutions, right, to their problems. Yep. And in this case, the problem cannot be fixed.
Yeah.
That can feel very overwhelming, especially if there's something about the patient or their family or the household that reminds you of yourself and your family. Especially let's say I'm sure this happened to you after you had kids. The second you had kids, anybody that had something serious happen to their kids probably tugged at your heartstrings a little differently than before you became a father.
Yes. I mean, I talk about it in my book. My first pediatric code was a child that was the same age as my child at the time. And it hit a million times harder than it probably would have. So, yeah.
Yeah. It's totally different. It makes it's a lot more challenging to compartmentalize that when they're relatable.
Yeah, I agree with that completely. These first responders who feel emotionally numb after repeated notifications, do you have any advice for them that just, find themselves in that sort of headspace?
I'd say, could you say more about that? Are these first responders that feel numb only with a notification, or is this kind of an ongoing bigger thing? And are there coping mechanisms at home that they're using?
I would say only from the death notifications. Just
okay. Number one, I suspect it's not limited to death notifications. Number two, I think it's a survival skill at that point. It becomes a way to manage something. How do I put this? So we're perpetually dissociated from our feelings. Mind, body are not connected because it's a way of us surviving. And it's not helpful to compound that problem with things like alcohol. Alcohol is probably one of our most common coping mechanisms. It's the easiest accessible. It's the most, socially acceptable, and it's legal, as long as you're home and not threatened. And so I think that this inability to connect with our emotions, sometimes it's pathology and sometimes it is plain survival. So sometimes we need to compartmentalize to survive that emotionally. But then when you go home, do you take that armor off and feel that out? Or do you just bury it with more alcohol? That's where it becomes a problem. So I think to a degree, having this separation and being able to separate your emotions while you're working up a cardiac arrest is not the time to connect with the crying mother. It's just not. You need to be able to tactically do your job. And you need to be able to, like I said, separate those two things. But can you go home and process that? Can you go home to your spouse, to your kids, to your friend, and talk about that? Or do you just keep shoving it down and then it becomes a compounded problem over time? And then you don't connect with anybody, regardless of the setting.
Yeah, I talk about that constantly, just shoving stuff down and letting it build up. That's so important to be able to go home and, talk it out with whoever you can and process those type of experiences we all experience. It's so important.
It's crazy because it's our superpower, right? Like, what are you can think of a million things that you didn't think twice about being able to do that most people would faint at the idea of hearing. Whereas that's what makes you really good at doing your job and really ideal for it. But, there are stuff that need to be dealt with eventually. Like when we don't do it ever, that it becomes a problem.
Yes. This is a great segue into the next segment. You mentioned you have a PhD in mental health, correct?
The PhD is in death psychology, which is
death psychology. Yeah.
Death. So not death, but kind of like it's all the subconscious work, like all the subconscious processes that are, influencing our conscious behavior.
How was that whole process and schooling for all that compared to medic school?
It was actually a lot of fun. I mean, the dissertation part was really hard, having to write, the largest paper of your life. I mean, I definitely shortened years off my life and added gray hairs. It was about a two years of writing one paper.
Wow.
But the classroom time itself was very special. I really enjoyed it. I was in person. I met my best friend there, and her and I have been inseparable since. And it was a great experience, and I think it really complemented a lot of the stuff that I had seen, both when I was in the field and since then, what I'm witnessing in our first responders and mental health.
How soon after you got your degree did you start doing these CEs and these talks and everything?
Oh, I was already doing them. I'd say I started my, I'd have to look back. I wouldn't, don't quote me on this, but I think I was in my master's program in 2016 or 17. I don't remember if I think I started my PhD in 2018. Things just get blurry after a certain time, but I would say I did start teaching this curriculum like right at the time that I was finishing my master's. So I was doing it before, and I'd been public speaking since 2018.
Okay. All right. Moving on to the mental health aspect, what are some of the quiet warning signs that someone is not coping as well as they think they are?
I think that any change in routine, big changes in routine, especially anything that involves community. So people who start withdrawing, reclusing from themselves, from their, there's a difference between needing alone time and isolating yourself. And the difference between what that looks like from the outside is very hard to discern. I think we even miss it ourselves unless somebody very close to us can have that honest conversation. But one thing I've come to understand about stress and cortisol is that we also have a tendency to release oxytocin, which is it's a connection drug. It's a connection hormone. They call it the love drug. It's the hormone that spikes during childbirth, when breastfeeding. It's the hormone that helps to bond two people together when you have a hug that lasts more than 20 seconds. So it's got all these warm, fuzzy associations, but it's also a stress hormone. And the reason why why oxytocin also spikes during stress is because it's literally our biology wanting us to reach out to others for support. And when that mechanism fails and we aren't doing that, or we don't have somebody to turn to, I think that can be probably one of the biggest warning signs.
Yeah, I talk about that a lot. After I experienced that first pediatric cardiac arrest, I came home and I shut myself off to my entire family. I didn't want to be around my wife and my children. I convinced myself I just needed alone time and sleep, and it turned into isolation.
Yep.
And what ended up helping me was being with my wife and children and getting myself out of that headspace.
Good. Yeah, I think a big red flag that I've come to identify as well is when providers don't want to work with a therapist. This isn't something we can navigate out on our own. I've been in therapy for over 10 years. I would not be where I'm at today without it. Yes, I know there are bad therapists out there. I'm not at all discrediting. I know very specific cases, and I absolutely believe that they happen. But there are life-saving therapists out there as well. And I will never not recommend it. In fact, if anybody's listening now, you do not have to wait till something breaks to go see a therapist. It's why we get annual physicals. It's why we do cancer screenings. It's why we go to the gym. It's why we, watch what we eat. We're not going to wait till something's wrong to do something about it. It's the same thing with our mental health.
Yeah, great advice. Do you ever find yourself having to personally decompress after teaching or talking about these such heavy topics?
Every single time. Every single time. It's one of the most exhausting things that I do. And as fulfilling as it is, and as much as I can't see myself doing anything else, I have to keep that in mind. I have to keep in mind that it's something that especially there's people that come up to you and tell you some of the most heartbreaking stories.
Oh, yes.
And I have to acknowledge that that's something that I will, to a degree, absorb. And so it's about going, home and discharging that and making sure that I have some downtime and not overdoing it. That's why I have the online courses. When I first wrote the online course for death communication, I remember in my mind what motivated me to do it is I thought, I can't teach this every single time. I can't bare my heart every single time and tell this story, because it always tied back to not just my experiences as a medic, but also as, someone who's lost people, people in my life, important people in my life. And it's since become a lot easier. I've processed and worked through a lot of those losses in different ways that were kind of, needed some extra work at that point. But yeah, that's what takes a little bit of a load off of me, is I have the digital option, and then I have the in-person stuff. And then, as much as I might absorb, some heavy stuff, I take in some incredible energy as well, being in person. So it goes both ways.
Yeah, that's something I've experienced a lot as well, as far as receiving messages from people online and face-to-face conversations, doing these public speaking engagements after the fact. They'll come up and they'll just pour their heart out to you and tell you what they're going through at the time, what their department's going through at the time. And it makes me constantly remind myself why I'm doing this. I'm trying to help out other people and give them the proper tools to decompress and be able to fight through some of these experiences. But it does take a heavy toll on yourself, talking to all these individuals. But just like you, I try to find ways to decompress and not let it get to me too much.
Yeah, and we wouldn't have it any other way. And I think that, as long as, there's only been one or two times where I've had to, leave a disclaimer and say, I am not a therapist, but I'm more than happy to listen, because when I see certain things, very rarely, for the most part, people are jumping in my DMs or telling me stuff they're always welcome to. That's the whole point of my community, as I'm sure it is for you, is like, let's have a conversation about it. Let's air it out and talk about it, whether it's in the DMs or comments. That's what I'm there for, but I take care of myself so that I can be that person for them.
Yeah, I've had a lot of people reach out, and sometimes even spouses saying, "Hey, my significant other read your book, and they've actually opened up to me and talked to me for the first time in their career." So, why do you think that first responders struggle so much asking for help?
Learned behavior. Forefathers didn't do it. The people that taught us didn't do it. I think it's very much a learned behavior. And I think that, agencies and departments have made so many leaps and bounds since, I started in 2003. And it's a completely different system out there, even since I left. And still, I think they're falling short. It's not enough to just have a peer support program and a therapy dog. Like, come on. Like, get in there, offer them EMDR, get them give them options for ketamine therapy, have, psychologists and therapists available, third party, because EAP isn't cutting it. Get in there and get the leaders doing this work too. Don't just provide it to the leaders need to go first. Higher ups need to go first in cultural.
Do you have any stories of individuals that's utilized ketamine therapy and everything? Because I don't really have any yourself. Okay, perfect. I've heard a lot of things about it, but me personally, I don't know much about it. And I would love to gain some insight on that.
So I actually wrote my PhD dissertation on ketamine therapy for firefighters with PTSD.
Okay.
And so I specifically worked with firefighters, not because I didn't want to be inclusive of EMS, but the data I was working with, which wasn't limited to PTSD, it was suicidal ideations, addiction, moral injury, all that stuff like that. There was more data that I had to work with that population, and I wanted to speak to agencies. And maybe I'm biased because I worked for AMR for so many years, but I kind of thought, they're not going to talk to me. And I got quite a few union leaders, union presidents and whatnot to speak to me about ketamine therapy. Which a lot of really cool things came from that. And I think there was definitely some big stigmas identified. The biggest one being that, it's a controlled substance, so this can't be an option. This must be illegal. And it's like, no, actually, it's a Schedule 3, like all the testosterone that I know you guys are on. Same thing. Yep. You guys have a prescription for it, so it's allowed. Ketamine therapy is prescribed by either a physician or practitioner, PA, that kind of stuff. And it's given in a controlled setting, therapeutic environment. And it's basically an adjunctive tool to talk therapy. Now, you can go in and get just straight ketamine therapy at a drip clinic, and it would be therapeutic, but I am of the belief, and it's completely my opinion, that it has to be paired with talk therapy to be the most effective. It acts as a conduit to break down barriers and help you uncover stuff that you've kind of, dissociated from. The way I describe it is I had this patient that I ran on who had I don't know what she called for. I think hypertension, and she had a headache. all the symptoms of symptomatic hypertension. But when I got there, she had like an extra elbow in her forearm. And it looked healed, but I still asked her, what's going on here? And she goes, oh, I broke my arm when I was a kid and it never got set properly. So that's the way that it healed. I look at mental distress and mental injury, psychological injury like that, is that after so long, it's going to calcify and it's going to heal in the wrong position. But ketamine goes in there and gently breaks it, so to speak, so that you can reset it properly. So it gives you this kind of fresh opportunity to rewire your subconscious. And what you're going to have access to can sometimes be a bit of a crapshoot. And so you want to make sure that you have the support of a therapist to work through the scary shit. Like, stuff comes up. It's not pleasant. It's not always enjoyable, but it is it's doing work. You're going in there and you are working through some stuff that'll take you back to childhood. It'll take you back to your, generational trauma, that kind of stuff. When you have the right guidance and support from a therapist that can help you make sense of it in your current life, like, oh, I grew up in this kind of household, which explains why I am drawn to these types of relationships and why I'm tolerating and behaving like this in my work. It all just becomes an opportunity to integrate the things that come from the 1 hour infusion and plug it in and apply it to the rest of your life. And so it's been remarkable for me. Yeah. I know people that it doesn't work for, so it's not for everybody. But you are the one doing the healing. You're the one doing the work. You're the main ingredient. The ketamine just helps you do it better. It's like finding the right tool for the job.
I had no idea about any of that. That is very enlightening.
And I think anybody who's giving ketamine for pain management, okay, I know ketamine can be used for a lot of things. We call it the duct tape of the med box right now. But pain particularly, because most people's, not all, but most people's pain protocols or ketamine protocols for pain management reflect that of the amount of ketamine that you get in therapy. And so when you go in to get therapy, you're going to get a taste of what you've been putting your patients through. And it is very eye-opening. Especially considering most of y'all are giving it over 5 minutes, and you're going to get it over 50 to 60 minutes, and you're going to have a trip to the moon. So it does give you some empathy to start mindfully practicing that, because there's no other drug like ketamine in your med box.
Well, that's great to have another tool for the toolbox. If somebody listening right now is at their breaking point, what's the first step you would tell them to take right now?
Work with your therapist. You have to. And that just kills me. Like, I don't want people waiting till they're at their breaking point, because that's like asking someone with a broken leg to do jumping jacks. Like, that is the last time. I'm not saying not to try, but you have to work with a professional. Like, it's not enough to be, we're advocates, right? And we can be peers. Yes. But there's nothing that replaces working with a therapist. And if, ketamine isn't an option, please do EMDR. EMDR is so much more accessible. It's cheaper. It's more widespread. It is equally, I would say, as effective at a certain point once you get to so many sessions. And it's a better fit for some people too. But I'm a big fan of the work that EMDR can do to help sort out our brains. But please work with somebody. And that's why I say work with someone before you need it, because you don't have to earn therapy. It's not like a rite of passage. Like, you have to wait till you're, till you have the dead baby call, to earn it. It's like, no, just go now.
Yeah.
You're in this field, you probably need it. Okay. Because you wouldn't have if you did.
Yeah, no, I agree. So we'll shift a little bit into your story and your personal journey. I know you've talked about how you got into it and everything like that. Would you say that your line of work has changed you as a person outside of the job?
Well, that's a tricky one, because this shift happened as a result of me being abruptly pulled from the job. My back injury unearthed a lot of psychological stuff. And I think it's something I don't think a lot of people pay attention to. And I'd like to see not saying it hasn't been researched, I know it's been observed, but I'd like to see more on it, is how much does a physical injury from the job unearth psychological injury? And how often is it that, and I spoke to a couple of the union leaders that I spoke to that said, they've got, guys that are out on injury that end up getting prescribed, benzos, narcos, narcotics. They're drinking every day at home. Their mental health just goes into the gutter because this activated that. And then they're not at work and they're questioning whether or not their career's over, and it just puts them in a horrible place. And they're all, out of sight, out of mind. So they just fly under the radar until it's almost too late. But as far as I go, that injury took me out very unexpectedly and very prematurely. But I also think that I wouldn't be doing what I'm doing today had that not happened. Yeah. So I'm it's taken years. I grieved the end of my career for a long time. I kept trying to get back in. And my back was like, yeah, right. You were one sneeze away from another back surgery. But I think I might have found this eventually, but this, at least for me, I can say this for myself, I think it happened for a reason.
Yeah, no, absolutely. There's a bunch of individuals I work with. Luckily, I haven't got to that point, but they go on light duty because they have shoulder injuries or back injuries, and they're offered. Okay, I was gonna bring that up. I didn't know you knew that story.
About that, I hope you document it. I'm a big advocate for documenting injuries. I don't care how stupid they are.
It was documented. And so, I'll tell the podcast real quick for people that don't know. I experienced a back injury on New Year's Eve. We were all sitting in the recliners around the TV watching the ball drop, and I kicked the recliner back all the way extended, and my lower back locked up, and it would not release. And I started screaming, and the guys thought I was playing around, and they came over and they knocked me out of the recliner. And they did what firefighters do. They're laughing. And I was like, I literally can't get up. And I was like squirming around. They're like, oh, stop fooling around. And a structure fire came out, and I couldn't move. So they're like, all right, here's a pillow. And they laid a pillow on the floor, and I laid there until an ambulance could come. And they had to take me. I went and got some muscle relaxers at the hospital, and my dad had to come pick me up. And so they had to fill out workers' comp paperwork on the recliner injury for me. So that's been the only time I was injured. But it was documented.
I'm so glad it was documented. That's the thing, is these cumulative injuries happen at the most random times. Like, I was technically just walking when mine went out, but it was from an injury that I documented like 4 years prior, which was also, if I remember correctly, was also on New Year's Eve for me. Because the only reason I documented it was that I was working the next day, because I like to pick up holidays. I remember I picked up both holidays, and I was going to have to call off the next day. And at the time, staffing was so poor that if you called off on a holiday, they would give you an immediate final written. And I wasn't about to catch a write-up because I didn't want that on my record. And so I went into my supervisor's office and said, hey, I can't work tomorrow, but I need to write this up. I just hurt my back, transferring a patient at the ER. And that thing saved me, and AMR paid for my $30,000 surgery. And that was the cheapest surgery on the menu, by the way. These surgeries go upwards of $100,000 and more. So, I'm very, very grateful for that piece of paper and that day, fateful day.
Yeah, and that's something, luckily, my place of employment are very, very adamant about. No matter how small, they want to get documentation on it.
Don't ever let anybody talk you out of it. Write it up.
Yeah. And like I was talking about earlier, the, people be out a few months to, a year for major injuries on the department. And I think that time at home, even though I haven't really experienced it, could start messing with you, not realizing, because, you want to be at your job and you love your job, and it's not good for you mentally, like you were talking about. And, that's something we got to take care of each other on, because especially the people that have to do light duty and go just pretty much do errands for the chief, that can really mess with you, having to I couldn't imagine.
Yeah, not fun.
when you're doing this emotionally intense work, how do you protect your personal relationships with individuals?
Hmm. Say more. Like what? When you mean like the
So just just personal relationships, loved ones, family members, friends. How do you protect these the integrity of them? Because as you know, we all experience trauma, and it can mess with our psyche.
Oh, okay. I see where you're going with that. So how do you protect your family members when you're going out doing this horrific stuff at work at times? By taking care of yourself. What you asked, to a degree was more external. Like, how do I protect them? Like, how do I do this for them, with them? And really, it's internal. And everything that you work on internally will, as a result, benefit the people around you. And so one of the things we do, I think, and this is my opinion, is as first responders, as public servants, is we serve ourselves last. And you have to serve yourself first. You have to take care of yourself first. And, I think that parents are sometimes the worst offenders because you're conditioned to serving yourself last, both at home and at work. Yes. And so it's really learning that it's not selfish to take care of yourself and to realize that, you want to ask me, the number one problem that we have when it comes to our mental health is a lack of self-love. Everything about therapy and the work that we do is about coming back to ourselves and learning how to love ourselves, because every relationship you have is going to be a reflection of the relationship you have with yourself first.
Yeah, I agree with that. Yeah, great advice. This last one on this segment, if you could go back to younger you on your very first day, what advice would you tell yourself?
I would keep my weight down. I'm sorry, but I think that contributed to my back injury just as much as lifting heavy patients. I'd work on my core. I would get a therapist, because I think a lot of us actually were drawn to this field because we had traumatic childhoods, and those things will come back to bite you in the ass at some point. There'll be some call that, I think calls can be traumatic, but I think oftentimes there's a trigger for things that were already existing all along. So those would be a couple of them. I don't think there's anything else. I know there's two more, but I can't think of them right now.
So we'll talk a little bit about the social media side of everything you do. So what do you think social media gets wrong about first responder mental health?
That we haven't figured out? I don't know. Sorry. I'm not saying that to be pessimistic or to say that, what's being done is being done in vain. But I think that sometimes, especially those of us who are in the space of mental health advocacy, we're surrounded by it. So I think our lenses might be skewed in thinking that we have a better handle on it than we actually do.
Yeah.
And I think every time there's another suicide, I go, okay, we really don't. We're missing the mark somewhere if this keeps happening. I would say social media too isn't real. It's not real. It's the polished version of people. It's attention is a currency, and so I think there are ways to show the public what EMS goes through, for sure. More than ever. But I think connecting with people in real life is going to be more important than ever, especially as all the robots start taking over our social media.
Yeah. There's a lot of bad aspects of social media, absolutely.
Sure.
But how do you think platforms like Instagram can be used positively in this space?
Oh, I'm equally as hopeful as I am pessimistic. I think that there is a light and a shadow to everything in life. And I think that one of the things that social media has done is it's decreased barriers to this kind of knowledge. Like, I think about like when I was a newer medic, like it wasn't cool to be smart. Like, you have these, accounts like World's Okayest Paramedic and, pre-hospitalists, and they're really making education look cool. It's like, oh, these people that we look up to, like It's not revenge of the EMS nerds anymore. It's like uncool to not know your protocols, not know your stuff, and not like question how to be a good advocate for your patient. Like all the uproar over the AHA updates. I've been an instructor since 2008. I've been an AHA training center coordinator for 2 training centers. I am still an instructor against my will for all 3 disciplines. I can tell you, I have never seen so many people commenting on it. And it was kind of cool. Like, I mean, it kind of got, people were getting involved. I'm like, we've never had so many, people were asleep 10 years ago. They weren't caring about this stuff, or they were barely talking. So it kind of created a bigger water cooler. And where at least on an ambulance, you're kind of siloed. It's just you and your partner, which can kind of be fun. But you don't have those round tables at the dinner table and at the, drinking your coffee in the morning with your crew and talking about all this different stuff. And so I think it created that for people that didn't have it. And you got to see how, wow, this agency over here is doing that. We should do it too. And then I think that's what really helped get things progressive. Not to mention all the mental health aspects of it as well.
I think Lucas device was trending on those last updates because I've never seen people talk about the Lucas as much as that day.
It was free advertisement for them, honestly. I mean, any publicity is good publicity.
Yeah, exactly. I was, when I first started at my full-time department, they had already had Lucas devices, so that was pretty much all I knew. And I don't know. It's just probably half my videos are talking about Lucas devices because people relate so much to them now.
Have you had them wake up your dead patient yet?
Wake up the dead patient?
Yeah. Consciousness?
No, personally, I've heard stories of people on the department, but me personally on the runs, I have not.
Anecdotally, I've heard more cases with the Lucas device.
Yes.
Anecdotally. I believe it was the state of Indiana. I think they were the first in the country. We only have like 22 places, at least last they did a review, that have CPR-induced consciousness protocols. So patients who are pulseless and apneic, they're getting worked up and the compressions wake them up. People are like, they don't know what to do with that. More than likely, you should be giving ketamine. But they, Nebraska. It was Nebraska. They had a statewide initiative where they they got like a $6 million grant to deploy and train on the Lucas devices statewide. Is it Nebraska? I'm gonna have to look at it. You're gonna have to pull me out. It was Nebraska. And then they were like, oh, our patients are waking up. We need a protocol for this. And so pretty quickly after that, once it was like in 2015 or 16, they deployed it. They had people waking up, and statewide they created a protocol, and they were the first.
Okay. Huh. I didn't know that.
Yeah. Pretty cool. I mean, weird, freaky, not great.
Yeah. So, everything, how long has your social media account been live?
I think 2018.
2018. So, I'm sure just like any other account, you've upgraded and got into more different things. And what would you say is next for emergency resilience, or what would you like to accomplish in the future?
Well, I've got a handful of online courses. I should also plug this because it's free, but if you're interested in ketamine therapy and you go to my website and you can find my website through my Instagram, go to Emergency Resilience, go to the link in the bio. I have a free 2-hour CE course on ketamine therapy. So it's nationally accredited. It's me chatting with you about all things ketamine therapy. And, how to find a therapist if that's something you want to work with, or like ketamine specific. But I'd say I want more classes. I teach a lot in person, and the time it takes to produce the class, because I'm unfortunately my biggest obstacle when it comes to creating something, because I want it to be like perfect. One thing you will get is a very well-researched product. So I do have pretty much anything weird and that I can tie back to mental health. So I do have a class on CPR-induced consciousness, and I I talk about it from the position of moral injury. Like if you don't train, if systems and organizations don't have training and education and protocols in place for their providers, they're setting them up for a moral injury because, I mean, I've been told it's from a number of people how traumatizing it leaves them to be doing compressions on someone that's begging you to stop.
Yeah.
When they have no pulse.
Yeah.
I hope you don't find out one day. So.
Yeah, I hope not. You mentioned, I'll touch on that real quickly. You go around and do these talks at different places. What's been the favorite place you've presented a topic at and delivered?
The topic or the place?
Just place in general. It can be any topic you've delivered. Just the presence you felt in the classroom, and just location, and I don't know, just all of it in general.
New Holland EMS in Pennsylvania, 100%. And it was really cool. And number one, they have an EMS chief there that I have never heard his name. I've never heard anybody else drop by name more than their EMS chief. He is extremely well respected by their community. It's a really big Amish community as well. And so I got to be exposed to a completely different culture while I was there. They are accessible. They create these accessible points for those in the Amish community that go through EMT school because everything is digital and that's, a barrier to education for them. So they create opportunities for them to do everything, old school, on paper and books. And also like the women get to wear tactical skirts, which is really cool. And so, and they have a really robust initiative to offer training. And they brought myself and Dan Sundahl and Destiny Morris, who's a first responder therapist. They brought us all out one year, and we had an incredible time with that group. I mean, they were just so hungry for education, and it was a beautiful area as well. And I have a lot of respect for that department, that agency. And every time I talk about leadership, somebody's in my DMs talking about Chief Fisher every single time. And I just think that, yeah, and he's so humble about it. He's going to, probably not like that I'm talking about him right now. But honestly, if anybody is in a position of leadership, I hope that they can be mentored by someone like him because he's obviously doing something right.
Yeah. I'm brand new to this. I just started and you've been doing it a while, but I'm sure you agree. Just me doing it these last few months, I've been so motivated by meeting different individuals from different areas of the country and hearing their stories and hearing what their department's doing. It's just, it's one of my favorite things about it. It's so cool.
It really is. It connects you with people. I mean, I had no idea what it was like to run in a rural environment until I, spoke to a group of, EMTs that, taught me that. Like, that's what I mean. Like, I learned from this community just as much as they learned from me. And there's just, we haven't even scratched the surface when it comes to the things that we get to learn. And so being able to travel around the country, work with different organizations, I started working with a train company. One of the largest train companies in our country, and that has been eye-opening as well. So it's like anytime I get to learn something new at an intersection where I get to teach them we can't put a price tag on that. It's so cool.
Absolutely. Well, these last few questions are just a little bit lighthearted questions, just little funny ones. Coffee, energy drinks, or pure spite? What fuels you? Coffee.
Yeah.
I wish that was my answer.
My fiance drinks every morning.
Okay. Gotcha. You got any particular place you like coffee at or particular kind?
In bed, usually. No, I'm just kidding. No, I mean, I'm mostly a black coffee drinker. Once in a while, I'll get a little crazy with the holiday drinks and stuff like that. But we just have an espresso. He pops in a pot, and hot coffee is good for me.
Heck yeah. If you weren't doing this, what would you be doing in life?
Background investigator. I would love to do that. That would be fun because I'm really good at finding things out about people.
Like internet stalking? My wife's good at that.
I impress myself. Okay, so I'll tell you this. So my girlfriend was the one that I became best friends with in my PhD program. She's like, hey, I'm going on a date with this guy. And she'll, you check in. You meet people on the internet. You should probably let someone know where you're at. We share each other's locations. And so she's telling me where she's going, where she's going to be. And she gives me his first name. And I think like the restaurant he worked at. And I was like, oh, I've got within seconds, I had his name, last name, date of birth, his position at the restaurant. I mean, I'm just location of, where he grew up. I knew it very quickly. I'm not ashamed of it.
It's impressive how y'all do that. What's your favorite way to completely unplug?
Oh, I like reading a fictional novel. I'll get lost in that when I get into a novel. It takes me some time to get into it, but a fictional novel will do it.
Well, next year I'm going to send you. I'm actually in the middle of my fictional novel right now, so I'm going to send it to you. Hopefully you'll read it.
Can I ask a little bit of the premise?
Yeah, so it's called Time of Death. It's a horror novel about a paramedic.
Oh no, that sounds great.
It deals with him just dealing with his personal demons and maybe some actual horror stuff mixed in, and it's a really good idea. I'm biased, I know, but I feel like it's going to be good.
I love to see people, and that's one thing I will say this real quick before I forget, because that one thing about social media is I love seeing people in these licensed positions. Like, I follow a veterinarian, a nurse, a paramedic. I love seeing people take their creative work and share it with the community, the collective, and so you writing a book, having already written a couple of books and then now writing like a novel, like that's so cool. And you're teaching other people, like, that they could do it too. What stops them, right?
Yeah, I have all kinds of people message me like, how did you do it? And it's very, very easy to self-publish. And when I was little, I was the biggest nerd. I loved to write. And now I have a platform where I can write and people can read my books. So I'm just going to continue to do it till I run out of ideas.
All right, cool. Keep going.
Last question. If first responders really understood blank, everything would change.
Self-love.
Self-love. Yep.
That's what it comes down to.
I still struggle with it. Everybody struggles with it.
I'm telling you. And I've only, having been in therapy, for the last 10 years, that has been a big lesson that I've only been tuned into in the last, like, maybe 2 years. That's really what it comes down to. And I think the absence of it is really where our biggest problems come from.
Well, it's been an excellent talk. Thank you so much for coming on. Everybody go check out emergencyresilience.com. That was the website, correct?
Yes, it is.
Yep. I'm going to have my department holler at you to get some CEs as well, because I love the mission. I think it's needed everywhere. So y'all check out that website. Get you some good CEs for your department. It's very, very good topics.
Well, thank you so much. I appreciate it. I had a really good chat.
Awesome. Thank you. Well, guys, stay tuned. New episodes every other Monday, 7 a.m. Eastern. I'll see you on the